Hi, this is our educational video for the staff focusing in on a new concept for quality in terms of patient care after surgery. The term is failure to rescue, and let us take a few minutes to help share with you the concept and how each and every one of us can focus in to optimize outcomes for patients after surgery. None of us want to have a patient develop a complication after surgery, and we do many things already to try and prevent important complications after surgery. But a new recent focus and measure of quality has been on the concept of how a hospital as an organization recognizes these complications and how we intervene and how we escalate and how we communicate. And so the concept is, in this video, we'd like to provide you a structured approach to some of the most important complications after surgery and how we want you to approach them. If you look at the slide, you can see some of the points that we made before, where we talked about a marker of quality is the ability to rescue patients after a surgical complication. As you can see here on the slide, there are 4 that we're going to be focusing in on in this particular video. The first is pneumonia, the second is sepsis, then venous thromboembolic disease, DVT, and pulmonary embolism, and finally, gastrointestinal hemorrhage. Let's take them one at a time. Our focus for each one will have 3 components: prevention, recognition, and intervention. And a theme throughout all of these important areas is the concept of escalation, that if you see something, tell someone, and if the person doesn't respond in a timely fashion, go rapidly up the chain of command until you get the response that's required and appropriate. Let's start with pneumonia. As you can see here on the slide, when we discuss prevention, there are some important protocols already in place at the medical center. Those include the ICOF protocol, and we'll go over that more on the next slide. The second is early mobilization. And as you'll see as you hear the rest of this educational series, the focus on early mobilization is crucial to prevent some of the most important complications after surgery, and pneumonia is an important one. Thirdly here, we're focusing in on incentive spirometry, and actually that's part of the ICOF protocol, so let's discuss that now. The ICOF protocol, as you can see here, has numerous components. The first is the I, standing for incentive spirometry, the C, standing for cough and deep breathing, O for oral care, twice daily toothbrushing. U is understanding patient education, and this is crucial so that you are working closely with the nursing staff and the clinician staff to help optimize your own outcomes. G is to get out of bed, again, early mobilization, and head of bed elevation, which is important in the ICU and on the floors to minimize the risk of aspiration. In terms of pneumonia, now that we've moved on to recognition, let's point out some particular areas that might be hinting that your patient might be having an early pneumonia. So increased secretions, potentially a fever, a cough, potentially even decreased level of consciousness, and decreased oxygen saturation. These are important because they're somewhat nonspecific, but it's important that you pick up on them early before things get worse. In terms of intervention, you'll see some common themes. The first thing you should think about is escalation. I need to call for help. We start out here by mentioning, and I would equate them with each other, calling the rapid response team or calling the primary team, or both. Calling respiratory therapy to help if the patient needs nebulizer therapy. Considering cultures, antibiotics, and again, if things have gone quickly, does this patient need to have their airway secured, and does the ICU need to get involved? Our next topic is sepsis. It's similar, but the cause of sepsis doesn't necessarily have to be pneumonia, but prevention again, early mobilization is key. For surgical patients, wound care is important for a recognition of a surgical site infection. removal of central lines and Foley catheters as soon as is safe is absolutely crucial. It's been important and it remains important. Recognition here is the definition of sepsis: fever, elevated white blood cell count. If the patient develops tachypnea or tachycardia, you think about it. And one of the things that's important, and you'll see this as you go on with the video, is that these non-specific symptoms can be any one of these 4 important complications. Interventions are similar. Escalation: call the rapid response team, call the primary team, work with the house officers or physician's assistants or nurse practitioners to implement the sepsis bundle in a rapid fashion so that the patient starts to get appropriate resuscitation, so that cultures are obtained, that early antibiotics are given, and that a lactate is checked. Next, let's talk about venous thromboembolic disease, pulmonary embolism, and DVT after surgery. Prevention is something that we're all a part of already, and that early mobilization, again, to try and prevent DVT is crucial. Secondly, patients should meet criteria, if they meet criteria, for DVT prophylaxis, either with chemical prophylaxis, with sub-Q heparin or Lovenox, or mechanical prophylaxis with sequential compression devices. If you don't see any of them on your patient and you think your patient should get it, contact the primary team and do it right away. If you believe your patient may have developed a DVT or a PE, here are some of the signs and symptoms that you might see to recognize. And again, you'll see they're nonspecific, but they're crucial. A fast heart rate, that they may be developing early signs of shock with low blood pressure. Look carefully at your patient to see if they have swelling in their arms or their legs. Has the patient developed shortness of breath? And again, is there evidence of hypoxemia with decreased pulse oxygenation? Interventions are similar. Escalate. Escalate, escalate, escalate. Call the rapid response team. Call the primary team. See if the team needs an ultrasound machine to quickly see if there's evidence of DVT or upper extremity clot. And talk to the team. Will they be wanting to order heparin on this patient as treatment? Gastrointestinal hemorrhage is another potential complication after surgery, and let's go through what we can do to help in this situation. In terms of prevention, certain patients meet criteria to receive either an H2 blocker or a proton pump inhibitor. Touch base with the primary team to see if this is supposed to be on the patient. In terms of recognizing gastrointestinal hemorrhage, again, the patient may just start by manifesting with low blood pressure or a high heart rate. And again, for all of these, the high heart rate may be a concern for pain after surgery, but it's absolutely crucial that you think about some of these complications after surgery and that, we've treated pain already and the patient still has tachycardia. Maybe it's one of these 4 complications. Coffee ground emesis can be a concern, melena, blood per rectum. By that time, it should be somewhat obvious what the primary problem is at this point. Interventions, again, escalation is crucial, calling the rapid response team right away, calling the primary team. From a clinician standpoint at the bedside, making sure the patient has appropriate IV access and that the patient has an active type in screen, and finding out from the primary team if they want blood products to be delivered to the patient already. Time is of the essence in all of these, but specifically in a GI hemorrhage. So in conclusion, none of us want any of our patients to have a complication after surgery. But as we mentioned earlier in the video, the evidence supports that a marker of a quality institution is not only how well they prevent these complications, but how well, as an integrated healthcare team, the organization can recognize these complications, can rapidly intervene and rapidly escalate and communicate to make sure that all members of the healthcare team are aware that this complication has occurred and that they're aggressively intervening. What we don't want, and we'd like to conclude with this, is failure to recognize, failure to escalate, and failure to rescue. We hope you found this to be helpful.